Thank you. One thing about our trial is that it's very controversial, but I guess that's a good thing. I think it stimulated a lot of research to either support us or disprove us. So that's what science is about. And I'm just delighted to be here. I'm just so impressed with people and the interest in helping prevent this vitamin D deficiency. And I'm surprised, I guess I was kind of naive about what a problem it is here. So without further ado, I want to give you a little background on what interested us in even establishing cancer as a secondary outcome in our study. You know, the relationship between solar radiation and cancer mortality is not new at all. In fact, one of the first published reports was in the volume 1 of the journal Cancer Research about 70 years ago, when Apperly noted that there was an association between cancer mortality, and it was lower in the southern United States than it is in the northern states where you don't get as much sunlight. And at that time, there really weren't trying to get at mechanisms, but one thing that was proposed is that skin cancer is more prevalent in people who have a lot of sunlight exposure, and perhaps skin cancer somehow stimulated immunity against the solid, more serious cancers. But then I'm just amazed, there was just a dearth of any reports in the literature until 1989, when Cedric Garland and his brother Frank again noticed this gradient in this time colon cancer mortality, higher in the Northeast than in the South. And they were the first to propose that the underlying mechanism was related to vitamin D. And since then, an inverse association between cancer death rates and sunlight exposure has been shown for numerous cancers, and I just list some here. And most of this stellar work has been done by Dr. Bill Grant, who's going to talk more about this afternoon. But basically, this relationship has been shown all over the world and in various populations, so you can look forward to hearing more detail about that. And then going to a little bit higher level of evidence, there have been numerous studies where they did case control, nested case control studies, cohort studies, looking at the association between serum 25-hydroxy vitamin D and cancer incidence or mortality. As you know, 25D is the functional indicator of vitamin D status, and in the 1990s we were able to start measuring that, and there have been numerous studies. I just want to review a few for you. This is one that looked at risk of fatal cancer by quartile of 25-hydroxy-D, and in all my slides the highest level of 25 is indicated by the 4th quartile or the 5th quintile. In this study, was done in Germany in men and women who presented to a clinic for coronary angiography. So at baseline, their blood was drawn and 25D was measured, and then they followed these people forward. Their age was on average 62. There were over 3,000 cases of cancer of all types and 95 controls. And they enrolled in between 97 and 2000. The median length of follow-up in these subjects was 7.5 years, and the outcome was death, and that was confirmed by death certificate. And so what we saw, there was a significantly lower cancer mortality for those who were in the highest quartile of 25D, and this risk was about half compared to those who were in the lowest quartile of 25-hydroxy-D. So then prostate cancer is more controversial. Nonetheless, I'll show this study. This was a 13-year prospective study of 19,000 men, so an impressive number, and 149 confirmed cases of prostate cancer. And again, they found a lower risk of developing prostate cancer in those who were in the highest quartile, and the risk was about 70% compared to those who were in the lowest quartile of 25D. So equal time for women. This study was again done in Germany, and they looked at women and the risk of breast cancer. These were postmenopausal women, so they were older, over 1,300 cases and controls, and this was done in the early 2000s, and the outcome was histologically confirmed invasive or in situ breast cancer. We see the same display, so there was significantly lower risk of developing breast cancer in the highest quintile, and in this case the risk was about 70% lower compared to those who were in the lowest quintile, I guess it was in this case. And then the Nurses' Health Study in the US, older women in a nested case control study with 193 incident cases of colorectal cancer. They looked at quintiles of 25D. We see the same picture, and the risk here was cut in about half compared to those who were in the lowest quintile of 25D. So the preponderance of evidence from many studies, and I just touched on them, whether they're cohort, case control, nested case control, ecological, really supports that vitamin D decreases the incidence of cancer and the mortality from cancer. However, to be fair, there are studies that didn't find the effect, and many of those, if you really take a good look at them, there were problems with the design, but nonetheless, there were negative studies. And in fact, there are a few, I'd say a handful of studies that show that perhaps high levels of serum 25 might be harmful. And this is probably the first one that was brought to the attention and was published. It was a risk of prostate cancer by quintile of 25D. And this is an example of the U-shaped curve. Now in the US, the U-shaped curve is brought up a lot at meetings. You know, you worry about the U-shaped curve. And what they mean by that is that in the lowest levels of serum 25D, you have a high risk. And then as you get higher levels of 25D, your risk decreases, as was supported by a lot of the studies I showed you. But you also see that at higher levels of 25D, there's an increased risk. Now, I can think of maybe 5 or 6 of these studies. There are not many, and in several of them, the higher risk was not statistically significant. There are very wide confidence intervals. And Dr. Weiss addressed this yesterday in his talk. He noted that almost all of these studies that show a U-shaped curve were done in the Nordic countries. And as you know, the Nordic countries have a high latitude and they have extremely limited exposure to sunlight, and their vitamin D levels are low. And he says, builds a case that there's a risk of variations, big drops in vitamin D levels, so that during the summer these people can attain reasonable levels of 25D, but then during the winter months they drop precipitously. And he sees that there's a risk in the highs and the lows, and he has papers that are written to address this. So it's of concern. The data are very weak, but nonetheless, that is one thing that's holding back enthusiastic support for vitamin D in cancer in the US. So, of course, the highest level of evidence is still held to be the randomized controlled trials, and there have been 3 randomized trials looking at the relationship between vitamin D and cancer, and all 3 of them have had cancer as a secondary outcome. So that is one criticism that's legitimate in the scientific world. So the first one was a women's health initiative in the US, which you're probably aware of. There were over 36,000 women who were randomly assigned to vitamin D and to calcium. Now, it was 400 international units of vitamin D3 a day plus the calcium, or the other group got placebo for both. And the primary outcome was fracture. It's an osteoporosis study. And the secondary outcomes were colorectal and breast cancer. In this study, they found no effect of vitamin D on cancer outcome by intention to treat analysis. But the dose of vitamin D was very low, 400 international units, and Dr. Haney, with whom I work, would say that would barely boost, and his work would show that would barely boost your serum 25 levels. And the researchers reported that there was a very poor adherence. On average, the subjects took half of their vitamin D. So that you could say the average intake was 200 international units a day. So really, the study was determined to fail, I guess you could say. And another problem they reported was that 15% of the placebo subjects crossed over into the active group because they were taking outside supplements. So you kind of had a mixed bag. And then on top of that, 58% of the subjects were also assigned to hormone replacement therapy, which was part of the protocol. So you kind of had several things going on at one time. And in fact, this study was stopped early because they found an increased risk of breast cancer in the hormone therapy group. But on the other hand, in spite of the limitations, this study found a highly significant inverse association between the baseline 25D and incidence of colon cancer. So before any of the subjects were given study supplements, they drew their blood, and this is where the association was seen. And the risk for in the lowest quartile was 2.5 times greater than the risk for those who were in the highest quartile of 25D. So in a way, this study did have a positive outcome for cancer. Then the second study was also an osteoporosis study. It was done here in the UK by Trivedi, and they had over 2,000 British men and women in a randomized trial, and they gave vitamin D3 100,000 international units every 4 months for 5 years. So on average, the subjects were getting about 800 international units a day, and they found no effect. This actually shows their cumulative survival, but if you look at their cancer survival curve, it's fairly similar. And unfortunately, in neither of these studies did they measure 25-hydroxy-D on everyone at baseline. They did some on a subset, but they did not do enough to associate the levels of 25D with the outcomes. Our primary aim, as I mentioned, was to determine the anti-fracture efficacy of supplementation with calcium and vitamin D in a population of older women. Our secondary outcome was to determine the efficacy of supplementation on incident cancer of all types. I always want to point out I did get funding from the National Institute of Aging, and I was appreciative for that. So we randomly sampled the population, and I'm going to talk a little bit more about that because that's a particularly strong aspect of our design. And we enrolled 1,179 postmenopausal women who, of course, were older, and of course our emphasis was on osteoporosis, so that's why we chose that population. And it was a randomized double-blind placebo-controlled trial, and each woman was on study for 4 years. We followed them, and we assigned them to one of 3 groups. This was randomly. Calcium, either 1,400 or 1,500 milligrams a day, and the range is because we gave them a choice of which type. With one type, they were going to have to take 7 pills a day, and the other type, they could take 3 a day, but they were very large. So and we had it's always a challenge to get people to be compliant, especially with calcium. The second group was vitamin D3, 1,100 international units plus calcium. So our D levels were not that high, 1,100 international units. But bear in mind, at that time, the recommendations for this age group were either 400 or 600 international units a day. And then the third group was given an identical placebo for both. So our target population were healthy postmenopausal women in a 9-county rural area of Nebraska. Nebraska is right in the middle of the United States, and it's very rural. And then we limited our subjects to the rural area, and the reason was we wanted to do this population-based study, and everybody needed to have a listed telephone number. And we started the study in 2000, and a lot of people did not have listed telephone numbers in the cities, and cell phones were almost non-existent then, especially in the rural community. So we knew that we were able to find out that 95% of the people in these communities had landline telephones with listed telephone numbers. They were of any ethnic background, but I have to tell you, our cohort ended up being completely non-white Hispanic because that's the population of this community. And we required that they be living independently. Nobody was living in nursing homes or assisted living. Now, I want to talk a little bit about a population-based study. Many of you probably know about these, but if you don't, I just want to review. You know, in any of our human studies, what we do is we get a sample of people and we find out what happens in them, and then we want to make inferences to the larger population. So you want that sample to be as close in makeup as the population that you want to apply your findings to. Now, convenient samples where you advertise in the newspaper or you get your patients who might be interested often have built-in biases. In fact, there have been studies that show that clinical volunteer samples, a lot of times people are healthier, they have more healthy behaviors, and that's why they volunteer to be in a study, because they believe in health. And so probability sampling is the best way to obtain a sample that represents your population. And a simple random sampling is the easiest form of probability sampling. And in that, every member of your population theoretically has an equal chance of being selected to be in the study. And of course they can refuse, but at least you're going around and just randomly picking people. So we did simple random sampling, and we hired a survey company, Midwest Survey and Research, MSR. They were actually a market research firm. But they did all the initial contact for us. So they used a complete list of telephone numbers, and then they randomly dialed. And they went to every household that had a listed number, and they started asking questions. Is there a woman over 55 who lives in this household? And then they would go down with key questions to further eliminate it until we got our sample of 1,179 women who qualified for the study and agreed to participate. So it took them a bit of time, and we were sure glad we had a firm, because I couldn't have kept my staff calling that many times. So it took a lot of work and a lot of money, but they got them. Another thing about samples is you don't want to have too many exclusion criteria, because if you exclude people who have hypertension and you exclude people who have other things, you're not going to have a representative sample, because in a sample of older people, you're going to have comorbidities. So these were our exclusion criteria. We excluded people with a history of cancer, except if they had had skin cancers other than malignant melanoma, they could be included in the study. And if they had had any other cancer, but it was treated curatively more than 10 years before they were enrolled in the study, we accepted them. We also excluded people who had a history of chronic kidney disease or renal calculi because of the perception that calcium leads to kidney stones. Now that's not, there are data that say that's really not true, but there is a perception. And then because we were studying osteoporosis, we excluded people with Paget's bone disease. And every year we measured 25 hydroxyvitamin D. We used a radioimmune assay, and our lab participates in the quality control of Serum 25 assays, and so we were right on target when we were tested every year. So we have confidence in our 25D assays, and I just throw that out. There's a lot of variation in vitamin D assays, and that's something you have to watch for in studies as well as in clinical practice. And then also to assure validity, we had our supplement pills analyzed at the beginning and end of every year. We only used them for a year, and we analyzed them at the end to make sure they were potent, and they were. In fact, we targeted 1,000 international units, but they maintain, you know, the company will put in a little extra, And we had 1,100 international units by the end of the year. That's why we have that dosage reported. So we had these subjects come in every 6 months, and we counted their pills and gave them a new supply, reviewed their medical status, and all of our cancers were validated by medical records. And at the beginning and the end of the study, we did a dietary assessment, and we were primarily interested in their calcium intake. We really had very good pill takers. That's one thing about this population. They're very motivated people. They're largely from farms, and they're hardy, and if they make a commitment, they're going to stick with it, and that was definitely a strength of the study. So we defined adherence as taking at least 80% of their assigned doses. So for vitamin D, our adherence was 86%, which is very good. And for calcium, it was a little less, but still not bad. 74% of them took their assigned 80%. We also had these women stick on study. Of the 1,179 enrolled, nearly 87% completed the 4 years of study. And these were older women. The oldest one was 89 when she enrolled. We called her our optimist, and she finished the study. So we only had a 13% dropout, which is another strength, because when you have a lot of dropouts, it really affects the validity of your study. So basically what this shows is our subject characteristics at baseline by the 3 treatment groups. And they were on average about 66 years of age, average height. They were heavy. On average, their BMI was about 29. And they'd probably be heavier today. That was starting in 2000. Their dietary calcium intake was about 700 milligrams a day. But if you looked at their total calcium intake, along with the little bit of supplements they were taking, they averaged about 1,000 milligrams a day, which is pretty much in keeping with recommended levels. So this shows the baseline and 12-month levels of serum 25-hydroxy-D by treatment group, and this shows the change, and I've shown it in both nanomoles per liter and nanograms. So at baseline, their mean 25D levels were about 72 nanomoles. So they were not really severely deficient, especially by what I see here. These women were fairly sufficient. At 12 months, the placebo group held at the same place, as did the calcium-only group. The D group increased by about 24 nanomoles per liter, up to 96. So this is where we got our group with 1,100 international units, and about 96 nanomoles, about 38 nanograms per mil. And then for the remaining 3 years, each group tracked and stayed pretty much where they were here. Now this shows the distribution of our 25Ds at baseline in these women, and our latitude is about 41 degrees north. They were taking a little bit of vitamin D supplementation, but most of what they were getting in those days was from their multiple vitamins. They got a little bit. So if you consider vitamin D insufficiency below 80 nanomoles, about 65% of our population was vitamin D insufficient when we started the study. However, as you know, the Institute of Medicine in the United States and some European bodies suggest that the optimal level is about 50 nanomoles. And if that is the case, we had about 15% who were deficient, or insufficient, I should say. So over the course of 4 years, we had 50 cases of cancer diagnosed. Now, we didn't do any screenings. We didn't do colonoscopies. We didn't do mammograms. We didn't look for it. So our outcome was cases diagnosed. We had 50. There were 13 in the first year and then 37 in the remaining years. And this just shows the distribution of cancers. The breast cancer was the most common, and probably the next was lung, lymphomas. This figure is a Kaplan-Meier curve that shows that those that were free of cancer after 4 years of treatment in each of the 3 treatment groups over the whole course of study. So we see those who were free of cancer after 4 years in the placebo group, the calcium-only group, and the calcium plus D group. So the calcium plus D group had a significantly lower risk of developing cancer during this study than the placebo group, and their risk was 60% lower than those that were in this group. Now this group is in between, and this was, you could say there was a trend. This group's risk, the significance level was 0.06, and our cutoff for statistical significance was 0.05. But this group had nearly a significant difference in risk than this group, but it was not statistically significant. Then we had at least one lady who was diagnosed with cancer 3 months after enrolling in the study, so we decided to take a second look and excluded anyone who was diagnosed during the first year, thinking they had pretty far advanced cancer when they enrolled in the study. And so we used the same display here, those that were free of cancer in the placebo group, the calcium-only group, and the calcium plus vitamin D group. Again, it was statistically significant decreased risk, only the decrease in risk was even greater. It was 77% lower for those who were in the D group. So a pretty impressive decrease in risk. And this group held about the same. So cutting off those people who were diagnosed during the first year really didn't make a difference in their risk. So we wanted to look at it another way because, you know, people, just because they're assigned to a group doesn't mean they're going to stay there. So really what we're looking at as being what's effective is a 25D level. So we did logistic regression models and we looked at several things. So in a univariate analysis, we found that if you took their 12-month level of 25D, that was a significant predictor of developing cancer. So those that had a higher 25D had a lower risk. Similarly, if we looked at their baseline 25D, what they came in with, this was a significant predictor of who would or would not develop cancer. Then we did some combined models. If we put treatment group, so whether you were supposed to be taking calcium and D or placebo, so which group you were in, plus the 25D, the one that was statistically significant, the only one, was the level of 25D, which would be more important, again, than which group you were assigned to. And then if we put in treatment and baseline, both were significant predictors. In our study, interestingly, neither BMI nor age was a significant predictor. Our age range was somewhat tight, but all I can say is those were the data. Now, as you're probably aware, our study has been criticized a lot, and one of the primary criticisms is that cancer was a secondary outcome, and definitely we agree with that. In fact, as soon as I did the analysis, I called the NIH and said, I'm submitting a grant and I've got preliminary data, but I want cancer to be the primary outcome. And I did get that funded, but it took me 3 submissions. So I had this study as preliminary outcomes, and the reviewers still were a little reluctant. So on the 3rd submission, I was able to get funding from the National Cancer Institute. So there was a little reluctance there. And probably more criticism arises because of our small sample size. And all I'll say is that, you know, if you have a large effect and you see it in a small sample size, that's what it is. We're so caught up in large sample sizes, but when sample size is really important is when you're designing a study to make sure you have enough people in the study to find a difference if there is one. But this, I'm sure there could be a lot of debate, and there has been. Now, I want to stress again the strengths of this study. It was this population-based study. So it really was representative of the population. We had a rigorous design, and we were counting those pills and talking to people. You know, why aren't you taking your pills? So we were encouraging them. I can't give enough credit to my study staff because they build a relationship with these people, which I think is important in a clinical trial if you're going to get people to work with you as a member of your team. And that's really what it is. Without subjects, we can't do this. We had a very high adherence to our supplements, and we had a very low dropout rate. So our study was the first to report the effects of vitamin D status on all cancer incidents, and it was the first randomized trial that used an intervention sufficient to raise 25D to optimal levels, and we targeted a cancer outcome. Now, you're probably aware of this World Health Organization report. I think Dr. Grant's the one who said it's 400 pages long. He may have read all of it. I just kind of focused on the half a page or page they used to criticize our study. And I just looked at this word for word and spelling for spelling. I really do think they misspelled something here, but so they talk about an intention to threat analysis, and I and my statistician have never heard of that, and I Googled it. I think they mean intention to treat. And excuse my sarcasm, but I couldn't respond in person to them. So this is, as I said, a direct quote. They said that the subjects received the calcium only had a decrease in cancer risk of similar magnitude to those receiving calcium and D, and thus a correct intent to treat analysis comparing calcium plus D group with the calcium only group pooled with placebo, so dividing it into two groups, shows no significant decrease in cancer risk. Well, we think calcium is playing a role, and we're going to have a speaker talk about this, and I definitely, we believe that there is a role. There's similar pathways, and calcium has been shown alone to have an effect, or a strong suggestion of an effect in colon cancer. Another criticism was, in contrast, an intent to treat analysis when they pooled the two intervention groups versus placebo shows a significantly reduced cancer risk due to calcium supplements. So they really felt that the decrease in risk was due to calcium. And they said the methodology and statistical analysis of this trial have been much criticized. And they cited the letters to the editor, but they did not cite ours. So it seems there should be equal opportunity. And one of their main criticisms was that the cancer incidence was unusually high in the placebo group. Well, we went back to the National Serum Cancer Database in the US, and we went to our Nebraska Department of Health. And our letter to the editor pointed out that our placebo group that had an incidence of cancer that was right in the ballpark, as we say. So we did not have an unusually high level of cancer in the placebo group. So in summary, there have been a variety of research designs other than randomized clinical trials that provide, I think, pretty convincing evidence that vitamin D prevents cancer. We've had one randomized trial with all type cancers, a secondary outcome that reported a 60% reduction in cancer. You know, you'd be lucky if most drugs you get for things would reduce your risk by 60%, and they're much more expensive and they have side effects. However, many members of the scientific community, including the IARC from the World Health Organization, as well as our Institute of Medicine, find the data lacking support for a causative effect. In addition, there's still some concerns about long-term safety. I should mention that in our study. So 4 years is not a real long time, but that's longer than a lot of, very few people have data on 1,100 international units for 4 years, and 1,100 is not a real high dose. In our current study, we're giving 2,000 I take 4,000 a day, so 2,000 is still not high. But in our study of 1,100 given to people who took it over 4 years, we had no events that were related to vitamin D. We had 5 persons who developed a kidney stone, and 3 of those were in the placebo group. 1 in the calcium and 1 in the calcium plus D. So, you know, you can take that. We did uncover a few, maybe 5 or 6 primary hyperparathyroid cases, which you would expect. Those are often silent out there, and you start giving them calcium. But we were measuring PTH and serum calcium, so we caught those and referred them on. So we were doing community service there. But we didn't have cases of hypercalcemia. That, again, is the big concern with vitamin D toxicity. So currently, we have 2 randomized trials, and the world is, I think, looking for those currently going on. Ours, we hope to finish our recruitment this fall, so it's probably going to be about 5 years before we have data. We're recruiting about, we're hoping to recruit 2,300 women, and we're essentially repeating this design, but we're going to have 2 groups, calcium plus D and placebo, and 2,300 women, so a little larger sample size, and we're giving 2,000 international units. We wanted to get this done, and at the time we proposed the study, 2,000 was the upper tolerable limit, and that's why we chose that dose. If we could now, I would go higher. But I thank you for your attention, and I'd welcome your questions.
Have you thought about the other radiation? I mean, just intensity of visible light. Because if you take, if you were comparing, say, a British cohort and a German cohort in the spring, British, their thoughts turn to sort of romantic things. But the Germans, you see, suffer from the firm wind. And so they have a different sort of lifestyle. They're taking pills like anything, they've got depression, and it's quite surprising. I mean, when I went first to Germany, well, not the first time, because that wasn't a sort of official visit, but it was quite striking. So there is a sort of thought that there's a sort of sad idea that if you wanted to raise your mood, you would shine bright lights in the visible. And so I'm thinking about this because one of the earliest efforts I made was with a psychologist to look at, we looked at redheads particularly, and people like that, because there was a suggestion, which I was quite surprised about, that redheads tended to be disadvantaged in the social scheme. They got more likely to be bullied at school and so on. They're quite extraordinary.
We adjusted our 25D for season and found a very little difference. There was about a 3% variation. And these people are rural, and they do get quite a bit of sunlight during the, during the summer when they could benefit from it.
I'm Harry Korvat from Semmelweis University, Budapest. I would like to ask you, I don't know if you have checked it, but could you find any difference in the response on vitamin D supplementation between patients, healthy patients and patients with cancer?
I can't answer that, but we have geneticists in our lab who are looking at response to supplementation, and they're finding specific genetic differences in response variation to vitamin D supplementation. So I myself have not given vitamin D to patients, and so I don't know. I can't answer that question.
Thank you.
You mentioned that there were some concerns about long-term toxicity has been raised by a few individuals. What were the main concerns? What was the main concern?
Well, the main concerns was that they saw that for example, in the prostate cancer, I showed that in people who had, in men who had higher levels of 25D, there seemed to be a higher incidence of prostate cancer than in those who were in the mid-range. So it was just the incidence of cancer.
Thank you. We already heard this morning that vitamin D is associated with multiple other diseases, several dozen different diseases. In your study, obviously the numbers are limited to look at multiple diseases,
Our
but did you get
numbers-
any indication at all that any reduction in the other
No.
diseases?
No, and I should tell you, we didn't have an anti-fracture outcome, but unfortunately, after we started our study, the FDA in the US approved the first medicine for osteoporosis. So that kind of ruined our chances of seeing a fracture outcome. We did see an effect on bone mineral density in the group that did not get Fosmax or alendronate. But no, but in our current study, we have every secondary outcome you could think of because we have a nice sized cohort. You need to study all those things. Thank you. Good questions.
Thank you very much.